In this lecture, we are going to discuss infections and management of the lacrimal drainage system, starting with the dacryocystitis, which is infection of the lacrimal sac and is usually secondary to obstruction of the nasolacrimal duct. It may be acute or chronic and is most commonly staphylococcal or streptococcal. Now, first of all, we are going to discuss acute dacryocystitis, where the presentation is with subacute onset of pain in the medial canthal area associated with epiphora. A very tender 10-thread swelling develops in the medial canthus, as we can see here, and not only in the medial canthal area, we can see that the swelling is extending over to the inferior lid as well. Now, it commonly progresses to abscess formation, as it is shown in the picture here. The abscess actually has pus excretion, and it may be associated with preseptal cellulitis. As now, the initial treatment involves the application of warm compresses and oral antibiotics such as flucloxacillin or co-amoxiclav. Irrigation and probing should not be performed. Incision and drainage may be considered if pus points and the abscess is about to drain spontaneously. However, this carries the risk of a persistent sac skin fistula, as we can see in the picture here, that lacrimal fistula is shown here, and fluorescent dye is shown here, which is instilled in the conjunctival fornix and excreting from the fistula. Dacrocystorhinostomy is done after the acute infection has been controlled and may reduce the risk of recurrent infection and can result in the closure of the fistula, as it is seen here. The fistula is healed as the arrow is pointing towards it, and showing a closed fistula. So afterwards, the other infection we are going to discuss is, of course, chronic dacryocystitis. Presentation is with chronic epiphora, which may be associated with a chronic or recurrent unilateral conjunctivitis. A mucocele is usually evident as a painless swelling at the inner canthus, as it is seen in the picture here. This is a swelling, but if an obvious swelling is absent, pressure over the sac commonly still results in mucopurulent canalicular reflux, as it is seen here in this picture. Treatment is with dacrocystorhinostomy. To reduce the risk of endophthalmitis, postpone intraocular surgery if there are any signs of lacrimal drainage system infection. So after this, the next infection we are going to discuss is chronic canaliculitis. Chronic canaliculitis is an uncommon condition, frequently caused by actinomyces aureus, which is anaerobic gram-positive bacteria, and as you can see in the picture, it is a gram-positive rod. Now, it can occasionally cause scarring and canalicular obstruction. Patients present with unilateral epiphora associated with chronic mucopurulent conjunctivitis, which is refractory to conventional treatment, and there is pericanalicular redness and edema and mucopurulent discharge on pressure over the canaliculus, as it is seen here in the picture. There is a mucopurulent discharge here. On the pressure over the upper canaliculus, and a pulping phantom may be a diagnostic tool in mild cases. In contrast to dacryocystitis, there is no lacrimal sac involvement. Concretions, which are sulfur granules, are metabolic products of actinomyces and other hydrogen sulfide utilizing bacteria, and classically are expressed on canalicular compression or following canaliculotomy. As seen in the picture here, these are the sulfur granules, hydrogen sulfur. Sulfide is used as they are anaerobic bacteria. Giant fornix syndrome, DACRYOCYSTITIS, and lacrimal diverticulum may give a similar clinical picture. Herpes simplex is a classic cause of acute as opposed to chronic canaliculitis. Next is the management. A topical antibiotic such as a fluoroquinolone 4 times daily for 10 days may be tried initially but is rarely curative unless combined with a canaliculotomy with a linear incision into the conjunctival side of the canaliculus and curettage of concretions is done, and it pretty much resolves the problem. So that's it with the congenital obstructions and their management. If you like the lecture, please press on the like button and subscribe to the channel. Thank you all.